We're very pleased today to welcome Jane Owens, who's the Digital Implementation Transformation Lead, and Charles Frakes, the Privacy Officer from Joined Up Care Derbyshire Shared Care Record. They'll be presenting on how this was achieved, and the presentation will cover information governance, testing, training and communications and engagement. The presenters will give an insight into the different stages of implementation that were required. So the session will also cover how good governance has promoted working in partnership with supplier and provider organisations, and talk a little bit about the next steps being planned for the shared care record. As I said, this presentation is being videoed, so all those who don't want to see themselves on YouTube, if you could turn off your camera and ensure your mic is muted, I think we've probably done that for you. We'll be taking questions following the presentation, so please either post in the chat box or raise your hand. And we'd love to hear your thoughts and questions. We'll also be sending out the slides after the session, so you shouldn't miss a thing. But that's enough from me, so over to Jane and Charles. Thank you.
Good morning, everybody. Hope you're all well and you're keeping cool. So Charles and I are joining you today to speak about the Derbyshire Shared Care Record and how we've gone about implementing this as a shared care record for the citizens in Derbyshire. Next slide, please. So we were given a directive from NHSX that all England's health economies had to have a shared care record in place by September 2021. That directive did come quite late to try and stand up from nothing at all, a shared care record. So it was all hands to the pump to see what we could achieve in relatively short timescales. The aim of it was to provide an holistic view of a citizen's health and social care record for the purpose of direct care. And you'll see throughout the presentation, I mentioned direct care because that is what we primarily have gone out with. We have contracted to buy an analytics platform, but obviously that then would mean that we'd have to go out and have another conversation with the citizens of Derbyshire around that. So primarily it is for direct care. We chose to go down the route of a read-only access to records at the moment for Derbyshire hospitals. So that's Chesterfield Royal Hospital and also United Hospitals of Derby and Burton. So we are looking at obviously bringing on board many other provider organisations across Derbyshire, which will include the general practices, community, mental health, out of hours and social care, again, all for the purpose of direct care. Next slide, please. So when you start to think about how you're going to set up a shared care record, there are several considerations that you need to take. And some of these are bullet pointed on this slide here, but obviously the current landscape across all the providers. So what's out there? What's in place at the moment? What can you do with what's out there and in place at the moment? But it's very important that you keep an eye on the future, because some of the provider organisations may be implementing new systems, they may be changing systems, and it's important that you've always got that an eye on the future for the provider organisations. Once you've done that, you can then start to look at the feasibility of what you can do with those different systems. So can you call an API? Have they got file capability? Do you need to use HTML? Are they CSV files? As I say, keep an eye on the future landscape because things do change rapidly. And then once you've got a good overview of what exactly is going on across your locality, you can then start to look at your tendering process. So we use the LPP framework and they offered us guidance. We also knew that we wanted to have a tender process that was very in-depth, but also time focused. So we set up a task and finish group and we also had terms of reference for that to ensure that we got good governance around it. And we also had 9 professional evaluation groups. So these primarily consisted of the CCIOs or the clinical information officers. We had one from Chesterfield Royal, Derby Community Health Service, UHDB, and also a CCIO representing primary care. We also had primary care, technical, PHM analytics, because obviously we've got to keep an eye on the future, so we wanted to make sure that we were doing so. Information governance, which is always a biggie with these shared care records. Finance, the local authority, we bringing our provider organisations on board right from inception to make sure that everybody feels that we're transparent, open and sharing things as you should when you're implementing the shared care record. We also had non-executive directors and we had a system strategy, but that was read only. So with the purpose of all this, we as I say, used LPP, which is the London Procurement Partnership, and we made sure that they gave us some training sessions on how to actually go about the tender process. And within a very, very short period of time, we were able to make sure that we were adhering to good information governance, making sure that we were adhering to good policy. We were able to tender for a system supplier. Our system supplier who won the tender was Orion Healthcare. And primarily one of the things that we've always said is we wanted to work in partnership with Orion Health. We wanted this to be a true partnership relationship, very open, very, very honest, very transparent. So our requirements, obviously, we'd looked at what those were and we'd got our specifications. We went down the route to start off with as read-only. You've always got that balance as whether you go read-only versus read-write capabilities. But primarily when you're standing up a shared care record, it's about what have you got out there and what can you plug in to start building that information. So most of the shared care records have started with read capability, and then further down the line you then start to look at your read-write capability. For your implementation, are you going to go big bang or are you taking a phased approach? Within Derbyshire we took a phased approach, so we had a proof of concept where we were actually testing the connectivity between EMIS and GP and TPP GP systems to make sure that we could get the single sign-on configuration up and running, and we tested that, and that then meant that we could move into phase one. So we chose to go down the route of single sign-on. That's our default position. We do give portal access to named individuals, but that is very much kept as small as possible because we wanted the default position to be that they sign on to the host system, click on single sign-on, and it takes them into the Derbyshire Shared Care Record in patient context. So the other things to consider when you're implementing a shared care record is what technical resources are you going to need, because you will need them across the various organisations, because obviously everybody works differently with their systems, etc. You need to think about your project resources. So what do you need to actually get the project up and running and see it through to implementation? And as I've already mentioned, supplier and partnership relationships, which we think in Derbyshire are very, very important. So next slide, please. So gearing up. So we understood all the basics, but now we need to think about the technical bits. And also, what about communications, information governance, the reporting structure, clinical safety, benefits, the processes, procedures, policies and SOPs, testing, and also the future resources required for training. So I will go through certain elements of these as we go through the rest of the presentation, and then we'll discuss them in greater detail. Next slide, please. So communication. So how are you going to communicate across a system? So we're not just talking about communicating with individual provider organisations, we're talking about getting this message out to the wider system. So we looked at a communications plan. And when we looked at the communications plan, it was important that we identified certain individuals within the comms departments in the provider organisations that we could work with. We also thought about how we were going to notify our citizens. Because it was for the purpose of direct care, we used the Joined Up Care Derbyshire website. It was not felt that we needed to go out and do a leaflet drop for everybody, because we were saying this is for direct care only. That might change going forwards. We don't know yet. There's a lot of things on the landscape, and there's certain things coming up that may mean that there is a requirement at a national level to communicate with people about shared care records being used for other elements. And I specifically talk about medical examiner services, for instance. And then part of that, we also put most of the information that people required on our Joined Up Care Derbyshire website, because we wanted to be open and transparent with the citizens. They could ask questions if they wanted to, and there's also the opt-out policies and procedures on the Joined Up Care Derbyshire website, and Charles will touch on those later. There is also the NHS Futures websites. We found that they were very helpful for certain things around implementing the shared care record. So there's lots and lots of information out there, and as well as that, talk to other people that have got a shared care record stood up. Certainly very, very helpful to talk to somebody that's using the same supplier as yourselves. We found Dorset very, very helpful to us. So thank you, Dorset. Next slide, please. Information governance. Over to you, Charles.
This one's onto mine. Apologies, I was just typing a response back to the question. So for information governance, as Jane's already touched on, we took a sharing first approach to our model because we were using the Article 6.1e for public task for the legal basis. So instead of getting consent from all individuals, we've opted that any providers that would normally share information anyway via email, letter, and such for each other, we opted those citizens into the record for the purpose of direct care only. As part of that, what we did is use the information sharing gateway to collect all of the responses from the GPs. I think initially we had about 115, 120 GPs, and it took us, I would probably say, the best part of 9 months to a year to get everybody on board, but by the end we managed to get everybody on board. I think it's worth flagging up to anyone that is rolling out a shared care record that one of the difficulties that we had from the information governance side is that post GDPR it's been quite a challenge with some of the healthcare providers, especially in primary care, in terms of ownership of data. Now, as people will know from GDPR, the citizen or the data subject is the owner of any particular information, and as healthcare providers, we are essentially guardians for that. So where we have to share that information for their own health, which is part of Article 9 for the health and nurse care, we will do that. If we can go on to the next slide, please. One of the ways that we mitigate that and make sure that people only have the correct access for any information is via our single sign-on, which is the predominant model, and through our different role-based access codes. So to touch on the single sign-on, most information systems that practitioners would use on a general basis, we've tied it into what is generally the biggest system for most providers, so that when they look at a patient that they would in their day-to-day, they have an option to then view extra information about them within the shared care record. At the moment, we're working at about 95% of the people with access to our record have access in this way, so that we're really focusing on the local governance that's already in place to make sure that people have got appropriate access. By default, people won't just get access when they join. Each organisation will need to let my team know, and then we will give them access in line with what their local access would be. What this means then is that if a clinician or a practitioner leaves post, as soon as that local access is removed, it also removes automatically the access to the shared care record. So through the single sign-on, we've almost got a double gate in terms of making sure that we have correct access. Rob asked about multi-factor authentication. This will be a bigger part that we will look at later down the line, as there will be certain practices or certain clinicians that will not have access to a local system, especially when we look at other users in community that might not have a physical base or access to anything other than perhaps a web browser. Once that becomes more dominant or more predominant in those areas, multi-factor authentication is another aspect in which we can make sure that the security of who's getting onto the system is a little bit tighter, where we can't have that single sign-on. So to role-based access codes, we've currently got 4 levels, which range from administrators on the first level. The second level gives us actual administration from a clerical point of view in hospitals, so think kind of receptionists, any person that may need to know appointment and referral information but does not need to know a full medical record. Third level is for people that need to know summaries from GPs. So this is predominantly, in our case, social care, where they have opted to not want to know intricate details of a record, such as lab and radiology results. But then we've got the level 4, which is full access for practicing clinical staff, which gives access to any information that is digitized on the record. I've already talked about the journal and leaving process. So when people get access to the shared care record, they'll send a message across to us. We'll attribute it to their local login, and that will go through. If somebody doesn't use the system within 90 days, it will suspend it, just in case there is any delay or fallout from any local governance not shutting down accounts early. Generally speaking, most places tend to shut things down within a week, but 90 days is reasonable for where we pitched it. So we had a long conversation about this as we started to implement on what that level should be. For anyone that's worked closely with the clinical staff, I think you probably agree that 90 days is not always kind of too short for them in terms of all the different systems that they use on a daily basis. So where we are rolling out, and this isn't really a commonplace system to use, it gives us that little bit of leeway whilst also relying on the single sign-on and the other security elements to make sure that we're not just leaving access open and leaving us vulnerable, especially with everything that's happening kind of globally at the moment. Security has been a big key factor in that. Next slide, please. So specifically on my role as the privacy officer, I came in, I think, about a year into the implementation of the Shared Care Record. So before we'd gone live, but well before we were in a full position to go through. Jane said we'd gone through the basics. We kind of knew what we wanted. We knew how we would get the information in. We just need to make sure that we've got a few kind of policies and procedures in place for that. So timely on my part, very much. NHSX rolled out the information governance framework for shared care records as we moved from the local healthcare records to the shared care records. I think it was about 12 months ago now that this came out. And this gives everybody a really good framework on really the basics of what we need to do for a shared care record. So looking at our position where we are direct care only, this is perfect in that we can go with a implied consent from every citizen initially, in that their medical records would be shared in any system anyway. All we are doing is just making that system easier for the clinicians to use at any given point. One of the things that the framework does flag up, however, is making sure that there is a mechanism for objections to sharing. So there is a national data opt-out for anybody that doesn't want to share their information for research and planning purposes. With that not applying to us directly, what we have instead is a separate system just for the shared care record. So if a citizen decides that they do not want any information shared, we have a binary approach in that with a few checks, we can make sure that that particular citizen is removed from view for any actual clinician in. Now, it's worth pointing out for those that are implementing from a technical point of view that not all systems will have the ability to remove records. As Jane kind of alluded to earlier, the way that we pull records in will differ from system to system. So where we are pulling an API directly from, say, the GPs, for example, removing a record means that we just never pull that API, so we don't actually get any information into the shared care record itself. However, the main database that our system is built on is from extracts from both NHS Digital and from the acutes. Now, given that they are copies of the medical record, it's not something that we are able to delete for various legislations that are happening at the moment. But what we do instead is make sure that any citizen that objects and objects and proves that they are the data subject themselves, we can make sure that nobody else within the actual system itself can see anything of theirs at all. And that kind of leads me on to the next point about the subject access request. So again, at the moment, we are some point of a coordination with this. We've only had one access request into the system at the moment, but it was actually specifically asking for information that we don't currently hold within the system. Because it's only obviously digital information that we can get in there, the shared care record at the moment for us will not have a full copy of any medical record for any citizen at all across the patch. So what I tend to do is I will make sure that the citizen requesting knows exactly what is available in terms of the headlines before we kind of dig into it, then ask if they would like us to continue with that, or whether they would like me to actually signpost them to the source of the information, whether that's the acute or to the GPs, to make sure that they can get a full record of theirs. Some people might want both, which they're well within the right to do. And as I say, that just helps us to kind of coordinate it across. Next slide, please. So I'm going to throw it back onto Jane, and then I'll see if there's any questions I can answer in the meantime.
Thank you, Giles. So back to reporting structures and requirements. So we actually had an assurance board that we were using to report into to make sure that everything was on track, and we also had an implementation group with a weekly meeting, and you did need the weekly meetings when you first started off with the process. Towards the rollout of phase 1, which is to deliver the proof of concept, which is the single sign-on, plus DCHS, UHDB, and primary care information. So we had an implementation group that was really, really useful. We had good governance around it, terms of reference. We had a mixture of people on from all the provider organisations, and obviously it worked really, really well. So one of the things that we were looking at was BAU processes. So the implementation group now has morphed into 2 groups, one which is a strategic management group for the DSCR, and that will deal with obviously the strategic management of a shared care record. And then we've got an operational steering group for the DSCR as well, which is chaired by Charles. And we'll have a lot more operational input that will then feed up to the strategic management group. So the other thing you need to start thinking about is what reports are you going to be required to complete once you've received any funding. So obviously we received funding for the Derbyshire Shared Care Record, so we need to report back, and these are done through monthly highlight reports. Next slide, please. So this is a draft version because we're refining our governance processes, but this is the latest version because obviously we've gone to the ICSs, and it just really shows how we are going to function and have really good governance around what we're doing. Next slide, please. Clinical safety case. This is a biggie. So within our Derbyshire Shared Care Record team, we had specifically a very small select group of CCIOs. So we had one from Chesterfield Royal, We had one from Derby Community Health Services, one from UHDB, and then someone representing primary care in that role. We've since been joined by a 5th member from Chesterfield Royal Acute Hospital, and it's worked really, really well. So we had weekly meetings with the CCIO, so anything clinical or anything that we wanted to discuss with them about anything to do with the Derbyshire Shared Care Record or to take their view on things, it was really, really worthwhile doing. So there are 2 clinical standards when you are implementing a shared care record. There's the DCB 0129, and then there's another one for the deploying health and adult social care organisations, which is the DCB 0160. So a clinical safety case for a system-wide project, you can use a template that you're using for an individual organisation's project, but you need to start thinking the bigger picture with it, because you're rolling something across many, many provider organisations. But primarily, it is a clinical safety case. So you will find that clinicians and healthcare professionals are very, very keen to get this done, because you can't go live without getting your clinical safety case signed off. You may find, for instance, that social care don't want to see the clinical safety case or want to have eyes on it, or would just like it because they would like to file it in amongst their project documentation. So you need to have a named lead for your clinical safety case, and that's a person that is a trained clinical safety officer. There are standards that you need to adhere to, as I say, for the clinical safety case. You've also got, as I've already mentioned, you've got to have sign off for go live. You can't go live without it. You may go live and you've accepted some residual risks and you've got your hazard log, but they're all scored. They're all looked at from a clinical safe perspective. And if there's anything deemed that it's not clinically safe, you won't go live with your shared care record. But you can carry forward these residual risks. And in fact, we did take a couple of residual risks forward with us, which I'm pleased to say have now been rectified. But you've always got eyes on your clinical safety case, because it's not something that you do and then you put in a drawer and you don't look at it again. It's something that's a working document. That's what it's meant to be. So any further implementation that you do with your shared care record, always go back and look at your clinical safety case. Is it in there? Have you looked at the hazards and risks about it? Have you got your clinical safety officer to look at it? And there is a lot of clinical safety case documentation on NHS digital website. So then again, the help is out there, professionals are out there, clinical safety officers, they know what's expected of them, they know what they need to do. It was also taken back through the implementation group, and then it was signed off by the system-wide CCIOs and our clinical CCI, a smaller select group that we had looking at the DSCR. Next slide, please. Benefits. So we all want to know what's the benefits of these shared care records, apart from the fact that you've got citizens that haven't got to keep repeating themselves again and again and again. You know, you've got other things in play like duplication. There are phone calls potentially that are being made to chase up information that is going to be in your shared care record. It really does depend on what your shared care record is delivering, what your benefits will be. So you need to do your benefits case and then understand what methodology you're going to use for that. You've also got your benefits mapping, where you map where your benefits are and how you expect to get them. Are they going to be quick wins? Are they going to be short wins? Are they going to be longer term wins? Look towards the future with them, because not all benefits you will see the minute you switch a system on. It will build over time. Help is available. Jackie Bell from NHSX has been really, really helpful to us in Derbyshire. She has benefits meetings regularly for people that are implementing shared care records. There are other benefits leads out there across the country that are willing to share information and to help you out. There are some benefits that everybody's going to get. So don't reinvent the wheel. Don't make it a big onerous task with your benefits. talk to other people, see what's out there, and particularly look on the NHS Futures website again, because that has got a raft of information in it. So the other thing about benefits, of course, is to enjoy collecting them. Don't see them as something that is a must do. See it as a way of proving how good you are with what you've implemented. Next slide, please. So processes, procedures and SOPs. So that's the other thing that you need to start looking at before you go live is, okay, so we've got this system. How can all this work across the provider organisations? What's out there that we have got to adhere to? What do we have to take into consideration regarding how other people work? So you need to have your process. So define what your process is, organise the steps of that process, describe who you're going to need to be involved. Are there any exceptions to the normal process? Because what we do in health is not necessarily what other people do in primary care or in community care or in local authority. You really have to think very hard about the processes because you're trying to fit it across a system-wide multiple provider organisations. So the other thing is, are there any control points that are required? And I don't know what's happened there because I've got a number 6. So I think that's a bit of a rogue number 6, if I'm honest. I might have just got trucking and didn't quite know when to stop. So procedures. So document how your process is going to be undertaken. We've started to look at SOPs. One of the things that we started to do, well, I started to do when we first started looking at this, was we started to do process maps. And they were really helpful because they showed in a page how that process was going to work rather than wading through lengthy, wordy documents. And then from those, we then said, well, which of these do we need to document a process for? What do we need a SOP for? And we created SOPs for the standard ways to get things done, because that's the good thing about SOPs is it will standardise things. We also had to look at what policies were currently in existence and we had to accommodate. Or do you need to ask someone to change a policy to accommodate the shared care record? There's all these different elements that you need to take into account, and working with your provider organisations again, being open, transparent, asking them what their process is, asking if they've got a copy of any documentation that you can then have a look at. In some cases you can plagiarise that and just tweak it a bit, but it's a process that you have to go through. But as I say, work closely with everybody on these because they need to work for everybody right the way across the system. Next slide, please. Testing. So this was an interesting one for us. We chose to go for an external company to lead on our testing. But what are you testing? So primarily we were testing the connectivity, so the single sign-on and the system performance. What resource do you need to do the testing? As I say, we used an external company, a testing manager, testing lead. Who is going to be doing the testing? You need to have named individuals within the organisations. You need to have your test plans in place, test scripts, and then your test report with your pass-fail mitigations, because you will have some of those falling out initially, but then it's how you are going to rectify those or mitigate against them. Next slide, please. Training. So this was quite an interesting one because what we understood was that across the provider organisations, different people train in different ways. They use different mediums to train. So we pulled all the training leads from the different provider organisations. We set up a Teams group for them and we were able to share the documentation. But as I say, we had different mediums we used. So we had QRGs, which were our reference guides. We also had Orion Health used a company called Ideal that did some MP4 videos for us, just short bite-sized chunks of information. A lot of supplier input with this and also training plans, but one of the things that we wanted to do was not make it onerous. So we didn't mandate that people had to do the training. It was a recommendation. It's no more than 30 minutes, if that. It can be fitting around your day job, so you can do a 2-minute bite-sized video in the morning, another one at lunchtime, and one later on in the week if you needed to. But also, because it's a read-only system, then some people learn by just clicking and playing and having a look round and understanding it that way. So we didn't want to close down any avenues, to just get the training out there and to get people using the Derbyshire Shared Care Record. Next slide, please. Go live. So we chose to have a phased approach. So who was going to do that first? Primarily it was we were GPs, Derby Community Health Services, UHDB, followed by Chesterfield Royal shortly. And obviously I spoke earlier about how you pull the different information into the shared care record. So for the primary care, currently we're using the MIG data set. We're doing that until GP Connect's available to us. The acute hospitals, what we do with the acutes is we surface their CETO documentation through something called the XDSs, or Cross Enterprise Document Management System. So think of it as a big bucket at the front of the 2 acute hospitals, and anything that they put into CETO goes into the bucket, and then Orion Health, who are our supplier, pull that information and documentation from the bucket and then display it into the Derbyshire Shared Care Record. We have the phase 2, which we are planning towards at the moment, but that will be in line with our roadmap. So we are also bringing on board the local authorities, which we're currently working quite closely with, the City Council and the County Councils, to try and surface what they would like us to put into the shared care record, but more importantly, what is useful for someone to see to enable them to provide the direct care to the citizen in front of them. We've also worked very closely on our roadmap with Orion Health. We obviously tweak it and adjust things because we're planning to implement our Discover element, or the core elements of Discover, in September. We're also, as I say, bringing on board the local authorities. We are working with the Mental Health Trust, and it's really, really exciting what the future is going to give us. Next slide, please. So your key fundamental principles: working partnership, absolute must. Be open and transparent with your provider and your supplier. And yes, there will be things that you don't agree on, but you can work it through. And be honest, be transparent, and always do your PDSA cycles. So keep reviewing constantly. What have you got? Is it right? Can you do any better? And I'm talking about things like if you are using the MIG and then GP Connect becomes available, can you use GP Connect? How do you go about transitioning to use GP Connect? So it's continually looking at what you're going to do. 80-20 rule is a good one to go by with the shared care record, because sometimes, you know, it's not possible for you to have 100% of what you want all at the same time. So what is out there, get what you can, make sure that it's relevant. Don't start filling a shared care record up with anything and everything, because it then gets so that it's unruly and it's very difficult for the end users to use in a 10-20 minute consultation with their citizens that are sitting in front of them for direct care. Next slide, please. So as I've said before, ask other organisations. We've contacted Dorset, we talked to Cambridgeshire because they're on the same journey that we're on, because sometimes people will have done what you're trying to do and you may not have thought of the best way of doing it, and you could find out just by having that conversation. So the supplier that you're using, so Orion Health, I always ask the question, is anybody else using this functionality? If so, who is it? Can you put me in touch with them? Let's have a conversation. But keep the lines of communication open, talk to everybody, be open, transparent, and enjoy the journey. But keep an eye on the prize, because the prize is being able to provide a holistic record to enable the end users to treat their citizens in the best way possible, and also to make sure that you're providing information that the clinicians feel is useful and that social care feel are useful. Always keep that in mind. So there's been several questions in the chat, I think, but unfortunately I'm unable to see them. I think Charles has been trying to type away in between. So thank you very much for listening. If you want to get in touch with either Charles or I, you are more than welcome to do so, and we will help you in any way possible. Thank you.
Jane and Charles, thank you very much indeed. It's a real tour de force in terms of starting up a shared care record. That's absolutely fantastic. And I think many of us will kind of understand the hurdles and the challenges, but also the opportunities that you have faced and will continue to face. Charles has answered a number of questions around MFA, benefits, staff numbers and roles and types. Thank you very much for that. We have got a little bit of time for specific additional questions. I've got one. I was going to ask about training, and you covered that, so that was great. But just in terms of user numbers, I'd be quite interested if you can share some of that, and particularly with reference to GPs, because we found in Dorset very difficult to engage with GPs who are very information rich and who use other systems and don't want to particularly use the DCR. So I'm just wondering whether you've got any kind of any nuggets of information that you can help us with that.
Do you want to pick that one up, Charles?
I will, yeah. I think, Tony, that really mirrors our position at the moment as well. So the approach that we took when we launched was to get all of our staff users on board as soon as possible. So we actually launched with over 18,000 users for the system. Now, not going to blow the trumpet to say that we've had everybody go onto the system. We're currently looking around about 500-600 unique users to the system at the moment, but we have found that currently they're predominantly in the community, those that wouldn't have already had access to a lot of the information immediately anyway. In the last couple of weeks, we have had a big uptake of GPs, and as soon as they got their hands on it, they were using it quite furiously, I think is probably the best description I can use for it. In pocket, so it's what we're doing with the GP rollout currently is engaging on a one-to-one basis and really getting the benefit at each practice, which across the patch is going to take some time. But the initial communications I've had on that is that absolutely, as soon as we get the local information, the local authority information in it, I think we'll struggle to keep them off the system, because that's one of the things that they're really asking for in terms of easy access to. But whilst we are predominantly healthcare information in the system, the biggest benefit they get is timely access to discharge letters. So for half of the constituency where we've got information and documents from Derby, that's great, and that is being used now. As soon as we get the Chesterfield documents on board later this year, that will be a quicker response from all of them. So still a struggle on us, I think, is a summary of that one, but because the communications are open with the GPs, they can see the benefit of the newer information that's coming soon. So we're trying to keep the carrot alive, as it were.
Brilliant, thank you. And Andy has asked a kind of follow-up question, which I think you've kind of partially answered. What areas of the systems do your GPs find most useful? So you've touched upon discharge letters. Any other areas at the moment?
Again, it will be the mental health information that they are asking for, because that's historically been quite difficult to come by. One of the first instances that I had of that in post was actually coming from patients, specifically asking to make sure, because some of the information that they wanted at their GP, the GP didn't have access to for their mental health records. So although it's not driven by the GPs, that kind of information is wanted via the patient as well. And again, not there at the moment, but that one's much closer within the next couple of months.
Oh, that sounds really encouraging. Great. Thank you. Adrian has asked a question. Can you link records, e.g. patient stroke unpaid carers?
So currently we haven't got a patient portal, but we are looking to have a patient portal across Derbyshire. How we're going to do that is still under discussion. But what we do know is that there will be a single point of access through the NHS app, and that's what we will primarily work towards.
Excellent, thank you. I'm just kind of rolling back some of the earlier questions. I think you've probably answered them all. So if anyone else has got any last minute questions, do type away.
Whilst we're just waiting on that, I'll just flesh out the answer in terms of the structure at the moment. So so for numbers, so we've got a core team of about 5, myself and Jane, and some of the Joint Care Derbyshire partners from a strategic point of view make up that core. But as far as the administration of the system goes, we've got 2 members currently, myself and an application support specialist, which administrates the system. One of the benefits that we've had of the Orion system is that being a managed service, the actual technical administration is quite light, so it allows us to focus on engaging and getting those users on board. Now, as we implement more systems and add more modules to the system, we will definitely need to expand that. But I think what we've tried to do, both in the way that we've implemented, but the way we continue our business as usual, is really tie into those local organisation systems. So for the operational groups, we will make sure that we've got both IT and clinical heads on there, so that rather than having a separate team that has nothing to do with the day-to-day businesses in the partner organisations, we are getting direct feedback immediately from the people that it will affect. So very light team as the core shared care record, but really benefiting from the partnerships that we're growing across Joint Care Derbyshire.
I think it's also worth mentioning as well that Orion Health have uploaded some of the large user lists for us into the system, which has really helped us to be able to keep our team quite select, shall we say.
Thank you. I've got one final question, I think, from Glenn. Again, it's around the GP work with care records. Did the engagement of GPs ask them what they wanted to see in the Derbyshire Shared Care Record? So did you go out proactively and say, okay, so what do you really want to see from a shared care record?
Not initially, I don't think. I don't know, Jane, if you want to pick up, because I know the engagement started before I was in post. I can only kind of talk about what happened afterwards.
Yeah, so not initially, but through having the GP representation that we got on our CCIO forum, for instance, we were able to take on board what GPs primarily would want to see in a shared care record. So other organisations as well, we were talking to those and saying, well, you know, what sort of thing are you servicing from your different partner organisations? But primarily, as Charles has said, the benefit for the GPs at the moment is being able to see that discharge letter imminently. But also as well, when we bring on the local authorities, and I've recently seen what the Orion Health offer is for that and how it's presented in the record, really exciting stuff. That will be great for GPs. And also, as Charles has already mentioned, the Mental Health Foundation Trust as well, when we bring those on board. So as the record grows, it will become more and more a primary go-to to find out what's going on with that patient, person, citizen.
Yeah, I think it's fair to say if we tried to engage everybody, if we had tried to engage everybody at once, it would have been a free-for-all, and I don't think we would have made any kind of progress. But sorry, Glenn, I cut you off if you want to jump in.
No, I was just going to say thank you. I find, you know, GPs usually need a carrot, don't they? They need, you know, usually that's money. And if it's not, then they need something else that provides them with something that means it's less clicks or whatever else.
Yeah, and less clicks is definitely probably the biggest carrot we can give them. I guess the stick that has been positioned to them nationally is that the vast majority of GPs are joined up to the shared care record in their region. So from a patient point of view, it's making sure that as a GP, they're not leaving their patients out.
Can't hear you, Tony.
Yeah, Thank you so much, Charles and Jane. There's absolutely fantastic presentation, really detailed and really helpful Q&A session afterwards. I think you've really grown in leaps and bounds in a very short time. So just want to wish you all the very best for the future. And we're obviously keeping in touch through various forums. But thank you, and thank you to our audience. And